So now we'll move on to the next session by Dr. Wulan Anggrahini from Indonesia. I'll be talking on the role of fusion imaging modality in structural intervention. Dr. Wulan, please.
Thank you. Thank you, Dr. Asokan, and thank you, Prof. Khanna, for the invitation. Can I share my slides? Thank you for the invitation. So I've been assigned to give or share about the fusion imaging modalities in adult structural heart intervention, some of the cases that we had, and also give you the idea for the ease of the procedures. So in the last decades or more, there's quite a rapid development in the percutaneous treatment of non-vascular. What I mean to say is the structural heart interventions, name it like valvulars or congenitals, and also other structural heart interventions. And as for the conventional method, fluoroscopy is quite inadequate for the visualizing the detail of the cardiac valves, the detail of the structures in the congenital heart, and also the acquired defects. And we need the visualization of the soft tissue imaging and the 3D delineation of the heart structures, which is not visible using only the fluoroscopy or the standard contrast ventriculography guidance. And as for the procedures, the accurate procedural guidance is really necessary. And imaging modalities to support the structural heart disease interventions, either it's a 2D or 3D transesophageal echocardiography, or the multi-slice CT, or even sometimes we need the MRI for the diagnosis of the disease and to evaluate the adjunctive anomalies or abnormalities. And the second, we also need those modalities for the patient selections, whether it's suitable for the procedures or whether there's any contraindications. And we can also predict the potential difficulties of the procedures that we want to, before we take the patient to the cath lab. And the intra-procedural or pre-procedural guidance is necessary to evaluate the detail of the structure, to plan the techniques that we will use, or if in between we face some new findings, then we can plan accordingly. So here we try to show you some of the integrated imaging fluoroscopy method. The basic principle of the fusion imaging, actually, this is the example of echocardiography and fluoroscopy fusion. So basically from the fluoroscopy, you will have some advantages of the large view of the heart, but you will have quite a lot of radiation, especially in the structural heart intervention.
There's a message from Sujal Shah.
And you only have a 2D images unless you have a very good spatial, visual spatial imagination, that it will be one of the difficulties. When you use the 3D TE, or some people already use the TE only guidance, and you will have an advantage of no radiation, or if you fuse it, will be less radiation, and you will have an imagination of the 3D images and the definition of the soft tissue or adjunctive abnormalities. So basically in the using imaging, you will fuse the TEE and also the fluoroscopy in one overlay imaging. So you can see clear nicely the heart model under the fluoro overlay, like this mitral clip procedure. And if you choose the 3D, it will be this model that you will have. And after the echo fluorofusion, there's also the CT, the 3D CT fluoroscopic fusion that you can use, for example, like for this pulmonary stent implantation in some of the post-procedural of the congenital abnormalities open heart surgery, or even for the TAVI or TVAR, for example, we can use the 3D volume rendered and fluoroscopy fusion as for the modalities. So the sum of the application of the echo fluoroscopy fusion that we already use in our hospital, for example, the fusion imaging will help us a lot in the transeptal puncture when you can put the marking based on the 2D or 3D TE, and then when you overlay the picture, you will see clearly the where's the puncture site. And if you use the 3D, it may overlay like this, and you can even have a better view if you want the specific place for the transeptal puncture, for example, like for the metro clip or for the LA closer, when you have to find the, like, for example, the anterior inferior view place for the transeptal puncture. So yeah, this is for the just simple transeptal puncture that we did a couple of weeks ago. So using this fluor guidance, actually, I don't really need we can eliminate the pigtail marking, and also we don't need the spatial view for the puncture. Instead, we can just overlay the picture and we can have a clear idea where to do the transeptal puncture. And it gives us the real-time imaging, the quiet precision place of the transeptal, especially for the other type of the more specific type of the interventions. And it helps us a lot in the difficult morphology of the when we find the spatial morphology of the LA, for example, the very giant left atrium, or aneurysmatic septal, or the bulging intra-arterial septum. And it gives us less complications. So far, what we did in the hospital, we have 0 complication using this procedure and very less fluoroscopic time. And for the classic PTMCs, also we quite favor with this imaging, because we can see it very nicely. So for example, this is the female with severe mitral stenosis. But quite easy morphology. Actually, we can do it without this fusion imaging. But yeah, here to show you that we can do it in a very shorter time as compared to the classic fluoroscopic guidance, and it gives you less radiation dose. If you perform it here in the overlay picture, we can see it nicely. As for the difficult cases, here we have a female with a very severe Wilton score, and valve area is only 0.3 centimeters square. We find the LA pressure quite high, very high, actually 32 millimeter mercury, and gradient is high, and also very high, or suffer from secondary pulmonary hypertension. And you see here the morphology of the mitral valve is somehow, she had a very irregular calcification. We thought initially that there will be 2 exits of the from the mitral valve, and when we tried to cross the mitral valve, we had a difficulty because the balloon is just stuck here before it can be crossed. So again, we try to use the fusion imaging, and we try to use the what's called the over-the-wire technique, using just the exchange wire, but it kind of difficult. So we decide to change our strategy. We just put the balloon just on the ostium, and then we insert the Inoue wire, and then we can just insert the balloon very nicely using this guidance and also the over-the-wire technique. So this is after we can cross, and then we use the over the wire. We just inflate it, and we use the second ballooning quite easily, and then we get a very good result for the opening of the valve and also reduction of the valve gradient. And the other type of we can use the other as modalities for the congenital intervention. So this is classic perimembranous VSG, and then what we do is that we use the classic APVIC technique, and the fusion imaging help us a lot in the crossing using the cutting pigtail. The wire can cross faster as compared to the classic fluoroscopy guidance, and we don't really need to do the LV ventriculography, so it reduces the contrast. So you can see here that after we make the loop and then insert the delivery catheter to the aorta, and then we just deploy the device, and then it sits nicely in the left ventricle. And it also helps us a lot when we did the retrograde technique of the VSD closure using the aortic approach. So there's a female with high perimembrane VSD with the right sinus falciform aneurysm. If you see here, initially we thought there'll be the defect in the sinus falciform aneurysm, but when we did the aortography, we see like a small adjunction structure that we thought it might make us give us a difficulties. But then we try to use this approach of the fusion to cross the defect from the aorta, and then we just put the GR 7 French GR guiding, and then we can deploy the coronary multifunction occluder in the defect. Also, it gives a good result, and there's no residual shunt. And another case, we can also use it actually, in my hospital, we kind of fans of using this fluoro fusion imaging because it helps us a lot and reduce the radiation. And this is another case of male with perimembranous quite large with irregular membranous septal aneurysm. And if you see here, there's some of the long septal aneurysm with a double exit. So it helps us for the antegrade crossing without snaring. So we use the JR diagnostic, and then again we can just cross easily. And later we put the guiding in the LV, and then just place the device, and then it resolves very well as well. And some other, actually for VSD closure, sometimes it gives up a more, it gives us a shorter time, but it really depends on the case. So this is one of the examples that we use. So we put a marking on where the defect is, and then we can overlay here in the fluoroscopy, and then we just deploy the device as usual. And for the other cases, since we haven't got any patients, or actually we did, but since our country doesn't have a good insurance for this modality, so we haven't performed this. But actually, the fusion imaging, you can use it for the LA closure, mitral cleft, paravalvular leak closure, and it gives us a lot of help. Reduce the radiation and reduce the contrast use, and even give a better precision. So as a conclusion, the structural heart disease intervention is a growing field and getting more attention from the interventionists. And integrated fusion imaging facilitates the manipulation and alignment of the device or any intervention that we use to the target lesion. So it will achieve the procedural success more and with a less complication and lower fluoroscopic time. And the dynamic and interactive nature of this kind of intervention requires really a multidisciplinary team from the pre-procedural, intra-procedural, and post-procedural with the expertise in imaging and intervention. So finally, I would like to give an acknowledgement to our team in our hospital, and thank you very much.
Thank you, Dr. Wulan, for the excellent talk. And now we have seen how the technology made the complex procedure safe and simple by introducing this role of fusion imaging in the intervention. And now the topic is open for discussion. Dr. Samidani, anything would like to add? Dr. Wulan, what do you think that is role in mitral clipping? And do you think that is still change the strategy, present the techniques to incorporate the imaging while doing mitral clipping? Mitral clipping.
Okay. Personally, I haven't done any mitral clipping, Dr. Asokan, because yeah, again, it's very expensive, and in our country, we haven't got any platform, a good platform for the financial platform for the patients, and most I mean, almost all the, more than 90% of our patients are in the insurance. But as per se for the MitraClip, as personally, I believe that imaging will give us a lot of help, especially in MitraClip. For sure, before the procedure, we have to evaluate the detail of the structural anatomy in the mitral valve, and where's the exact defect, whether it's in the anterior or posterior, and what type of the defect, and whether it will be suitable for the mitral clips or not, or if we have to refer them for the percutaneous mitral valve replacement, or if it's suitable for the specific device, because the invention of the device for the mitral itself is growing and expanding from the we know that shape of a mitral clips that we know, and China is already developing a lot of types of the device for the mitral, from only the clipping or the suture, even the percutaneous suture, until the valve replacement itself. So in this case, the role of imaging, and if we perform that fusion, either it's the TE and fluoroscopy or the CT of fluoroscopy, it will be very useful for any kind of the structural interventions. Well, personally, I really love the technology because it gives me a reduction of the radiation, a less use of the contrast, and detail, like precision of the procedure itself.
Khanna.
Yeah. So this was very wonderful talk, Dr. Wulan. You know, I mean, we've been fortunate to have her in our cath lab for a year, and she's been a wonderful, you know, not only a fellow, she was a consultant already. And she had always had an interest in structural heart disease, and she is now leading the, you know, the structural heart disease revolution in Indonesia. I mean, it's wonderful that we can do so many things, but I also want to, you know, emphasize that fusion imaging is very important in vascular interventions too. I mean, we have some sort of a fusion capability in our cath labs where we fuse the CT images with our, you know, in the cath lab work. This is very, very important for, you know, doing vascular work, especially in two settings. One, in aortic interventions, especially the aortic dissections and aortic aneurysms, both for thoracic and thoracoabdominal aorta. It's also very important if you're doing chimney procedures or you want to do fenestrated grafts. And also if you are, you know, you really want to do in these interventions with very low contrast. It not only gives you a precision, but it also reduces the contrast volume. And in aortic work, as we know, we require a lot of contrast, and many of these patients have renal compromise. So this is a way forward, and I think in future, most of the cath labs would have fusion capabilities, not only from CT, but also from MR, from transesophageal echo, and also duplex. So a lot of things are being integrated, and the future cath labs would be quite ready with all these capabilities, and we would be able to do procedures with minimal contrast and sometimes even without contrast. So Wulan, thank you very much. If Samir has...
I completely agree with you. Yeah.
And if Samir has a question, then it's good. Otherwise, we can go ahead and for some other work. Wulan has a lot of roles in APVIC. She was here and she's leading the show, and probably she is presenting almost every day in this meeting.